Ladies and gentlemen, thank you for joining Lake Superior Quality Innovation Network, Understanding an MACRA Quality Payment Program, the Merit-Based Incentive Payment System, Quality and Cost Performance categories. Your host for today will be Michelle Dewey. You may begin.
Good afternoon and welcome to today's webinar presented by Lake Superior Quality Innovation Network. Lake Superior Quinn is comprised of 3 organizations. We have MPRO in Michigan, MedStar in Wisconsin, and Stratus Health in Minnesota to support the Center for Medicare and Medicaid Services priorities for healthcare quality improvement in each organization's respective state. Today's webinar slides will be available on our Lake Superior Quinn YouTube page within the next week. Speaking today, we have Paige Pagano, who is a clinical quality consultant at MPRO in Michigan, and myself, Michelle Dewey, and I'm also a clinical quality consultant at MPRO. We will also have Holly Stanhart here with us to help answer any questions at the end of the presentation. Holly is a senior clinical quality consultant here at MPRO. So now I will turn it over to Paige.
Thank you, Michelle, and thank you everyone for taking the time to call in today's webinar. We will answer as many questions at the end of the presentation. And if your questions are not answered during the webinar, please contact the QPP Service Center, or you can contact us here at MPRO, which our contact information will be listed at the end. So today we are going to go over an overview of the MIPS, or the Merit-Based Incentive Payment System at a glance, and then Michelle and I will help you drill down into the categories of quality and cost performance. So I'm going to start with an overview describing what the MIPS, or the Merit-Based Incentive Payment System, is, and then dive into the different subcategories and talk about eligibility. So the Merit-Based Incentive Payment System has 4 components. The first component is quality, the second is cost, and the third is improvement activities, and the fourth is advancing care information. The quality component is based on the former PQRS program. Cost is based on the value-based modifier program, and improvement activities and the advancing care information is improvement upon the meaningful use program. So what's the 4 components of what the MIPS program is, and how do you know if you're an eligible clinician? Well, the overall eligibility is you must bill Medicare more than $30,000 a year, and you must provide care to more than 100 Medicare beneficiaries a year as well. So you need to meet both of those criteria in order to participate in and be eligible for the MIPS program. Now, the clinicians that are eligible to participate are physicians, which include your MDs, DOs, chiropractors, podiatrists, optometrists, doctor of dental surgery, and doctor of dental medicine. Also, physician assistants, nurse practitioners, clinical nurse specialists, and CRNAs. So if you fall into those categories of clinicians, you can either participate as, sorry guys, these slides. So if you fall into those categories for clinicians, you can either participate as a patient-facing clinician or as a non-patient-facing clinician. Non-patient-facing clinicians, such as radiologists, pathologists, and anesthesiologists, are still eligible to participate in MIPS as long as they exceed the low volume threshold, are not newly enrolled, and are not already participating in an APM. The threshold for non-patient-facing individuals is less than or equal to patient-facing encounters in a designated period. In other words, if you have more than 100 patient-facing encounters, you are considered a patient-facing clinician. Now that's if you're an individual. What about if you're in a group? So a group of non-patient-facing clinicians is defined by greater than 75% of the MPI's billing under that group 10 during a performance period. So who is excluded from the MIPS program? As you can see, there are 3 general categories here. Firstly, if you are newly enrolled in Medicare, you are excluded from the MIPS program. Second category in terms of exclusion is if you are below the low volume threshold. As I said before, the threshold is charging Medicare less than or equal to $30,000 a year, or if you see 100 or fewer more Medicare Part B patients in a year. Lastly, you are excluded if you are participating in an advanced alternative payment model. Participation in the advanced APM in terms of making you ineligible for MIPS is if you receive 25% of your Medicare payments, or if you see 20% of your actual patients. Both of those criteria are applied to the extent of which you are participating in an APM. So here are the pick your case options for participating in MIPS. So as you can see, there are 4 options you can choose from. First is the test case, second is partial, third is full, and fourth is participation in an APM. The first option is the test case. This is if you're a clinician that isn't ready to fully jump into the MIPS program. Basically, clinicians that submit some data, including data after January 1st, 2017, will avoid a negative payment adjustment. CMS allows clinicians to choose to report on one measure from quality, improvement performance, or advancing care information performance categories. The partial year is the second option. So let's say that you want to participate more in the MIPS program, but you aren't ready to participate for a full year. What you can do is you can choose to participate for 90 days. If you choose this option, you may qualify for a small positive payment adjustment. Next, we have the full participation. So if you choose to jump right into the MIPS program, you can choose to submit all of your data for calendar year 2017, which will maximize your chance of getting the positive payment adjustment during that period. I do want to emphasize the takeaway here, though, that the positive payment adjustment is not based on the amount of data you submit or the length of time submitted. It is really based on your performance. Now, if you do not choose any of these options, you will receive an automatic 4% negative payment adjustment. So you can make the choice as an individual to participate in the MIPS program, or you can choose to participate in a group that you are currently in. CMS is able to define what payment adjustment we'll receive by using a combination of your MPI number and also your TIN number. So for an individual, their single MPI is tied to a single TIN, and for a group, 2 or more clinicians defined by MPI who have reassigned their billing rights to a single TIN. If you report your MIPS data as part of the group, everyone within your group will receive the same payment adjustment based on the combined group's performance. So for example, if the data you submit justifies you to receive a Medicare reimbursement increase, but the remainder of your group actually qualifies for a decrease, you will be paid on the combined rate, which in this case probably wouldn't be a positive payment adjustment. So if you're thinking about joining a group practice, you should make a point to know their payment adjustment score before you choose this option. Now, what does all this mean for you, what you have to physically have to do? If you're an individual or a group, there are several ways you can participate in the program by submitting data a few different ways. You can submit data through an EMR, through claims, or if you're part of a QCDR, which is a Qualified Clinical Data Registry. Now, submitting data as a group is similar. Groups of 25 or more can submit their data through the CMS interface, which is also known as GPRO. Or the CAP survey, which is also known as the Consumer Assessment of Healthcare Providers and Systems. So when does the merit-based incentive payment system begin? Well, it already has begun. The first performance period opened January 1st of this year and closes December 31st of 2017. No matter when you choose to start, the deadline for submitting data to CMS is March 31st of 2018. After that, Medicare will send you a feedback report to see how you did on your quality measures compared to your colleagues. After the feedback report, you may earn a positive payment adjustment beginning January 1st, 2019. So that's only if you submit 2017 data by March 31st of 2018. Also, if you participate in an APM in 2017, you could earn a 5% incentive payment in 2019. Now I'm going to go over the quality performance category for MIPS. So like I said before, if you're an eligible clinician, you can pick your pace for reporting to MIPS in 2017. So what this means for quality is you can report a minimum data just to test your pace, and also just to test your system and see if you need to make adjustments prior to reporting in 2018. Or you can report 6 measures, including your outcome measures, between 90 days and a full year. Lastly, you can report 6 measures, including 1 outcome measure for the full performance year. As far as the quality category goes, it is worth 60% of your overall score. So each eligible clinician will select 6 measures. One of those measures must be an outcome measure. If an outcome measure is not available, the clinician should select another high priority measure, which a high priority measure is defined as an outcome measure, appropriate use measure, patient experience measure, patient safety measure, efficiency measure, or a care coordination measure. Clinicians receive a minimum of 3 points for reporting depending on the performance and benchmarks for each year. And just to let you know, you can go to the QPP website under Education and Tools to look up the benchmarks for each measure. So if a clinician fails to submit any quality data at all, they will receive an automatic 0 points for this category. Also, just keep in mind that out of the 271 quality measures that are available, there are a variety of measures that are related to popular reporting programs in the areas of cardiac, diabetes, adult immunizations, and also behavioral health. Now I'm going to turn it over to Michelle and talk about the scoring methodology and the cost component. Thank you.
Okay. Thank you, Paige. So now I'm going to talk a little bit more in depth about the scoring methodology for the quality component. Within the quality performance category, clinicians will need to select, again, the 6 measures to report, including the outcome measure, and we do encourage clinicians to select measures that are related to your specialty and your patient population. Of the 6 measures, you will need to select 1 outcome measure or a high priority measure if an outcome measure is not available to you. Clinicians receive a minimum of 3 points for reporting and can receive up to 10 points, depending on the performance against the benchmark for the measure. You can go to the QPP website, and under the Education and Tools section, you can look up the benchmark for each measure. If a clinician fails to submit any quality data at all, they will receive 0 points. And a quick tip is the longer you participate, the easier it is to meet the case volume needed to receive more than the 3-point minimum. And bonus points are available, and I will talk about them in just a few more minutes. So for year 1, participants automatically receive 3 points for completing and submitting a measure. So if you were to submit any measure, either under the test category or for the full year, the minimum points you would receive would be 3 points. Alternatively, during the first year of the program, all clinicians can receive those 3 points just for completing or submitting the measures. You can receive the 3 points again if you are only submitting for the test phase. And so in order for clinicians' performance to be scored against the benchmark, they must be 20 cases or patients. And the measure also must have a minimum of 20 cases and meet data completeness criteria. If a measure cannot be reliably scored against the benchmark, the clinicians will receive the minimum of 3 points. So this slide goes into more information about the benchmark for the quality component. And the benchmarks are separated by measure and by data submission method. So there is a difference in the benchmark if an eligible clinician is reporting a measure through their EHR as opposed to reporting the measure through a registry reporting data submission method. Also, it doesn't matter if you are reporting as an individual clinician or as part of a group. The benchmark will remain the same. The 2015 benchmark reports are available on the QPT website, but they are not yet final. So now talking more about bonus points, there are bonus points available for individual clinicians as well as if you're reporting for a group. Clinicians will receive bonus points for accomplishing either of the following two requirements. So the first would be submitting any additional high priority measures in addition to the one requirement of the outcome measure. So you get 2 bonus points for each outcome measure and patient experience measure you report, and you get 1 bonus point for each additional high priority measure that's not an outcome or patient experience measure. And then you can also get a bonus point if you use a certified EHR technology to submit measures to registries or to CMS. So now we'll go into how you can calculate the total performance category score. The equation for that is the total quality category score is equal to the points that you earn from the required 6 quality measures that you report, plus any bonus points that you receive. And then that total score is over the maximum number of points that you could gain. We want you to know that your maximum score cannot exceed 100 points. So that means that you may complete several bonus criteria, but it will not exceed the maximum number of points for the measure that you report. So if you reach through the CMS web interface, you would belong to a group of 25 or more. The maximum amount of points you can receive is 110, and that is by reporting on 11 measures at 10 points each. CMS will also be measuring clinicians on readmissions, and this would be based on claims data. So if you have 200 or more hospital cases, you will be measured on the readmission measure and can receive an additional 10 points, which will take you up to 120 points. For those reporting through another mechanism or individually, the maximum number of points is 60. But again, if you meet the criteria for the readmission measure, you can receive a maximum of 70 points. Other mechanisms would be through claims or a registry or through your EHR. Okay, so now I'm going to give you a brief overview of the cost category. So first of all, the cost category of permits for the first year is 0% of your weight. However, clinicians will be assessed on Medicare claims data for 2017, and you will be given feedback to establish a baseline, but it will not affect your payments in 2019. The cost category replaces the value modifier program. There is nothing you need to do for this section, but I am going to explain what a cost measure is in the next slide. So what is a cost measure? A cost measure represents the Medicare payments, like under the physician fee schedule, items and services furnished to a beneficiary during an episode of care. The episode of care is the basis for identifying items and services through claims that are furnished to address a condition within a specified time frame. The goal of this category is to align it with the quality assessment and to therefore result in better patient outcomes and smarter spending. So there are 5 components to the cost measure, and number 1 is to define an episode group. And an episode group is things like surgery, mastectomy, and aortic valve replacement. Number 2 is assigning costs to the episode group. Third is attributing the episode group to one or more responsible clinicians. So this will help CMS understand what you do and what your relationship is to your patient, and will allow for the cost measure to fit with the type of care you're providing. Number 4 is risk adjusting the episode group resources. So so defining episodes to be able to compare like beneficiaries. And lastly, align episode group costs with indicators of quality to, again, improve patient outcomes and pursue smarter spending. So why are cost measures important? Again, the goal is to improve patient outcomes and lower costs. So through the cost measure, CMS can provide clinicians with actionable information that will lead to reducing healthcare spending and will promote the delivery of high-value care. So the three general types of episode groups include chronic conditions, which account for a patient's clinical history and health status, acute inpatient medical conditions, which are clinical concerns at the time services are furnished, and procedural episode groups. So basically procedures with a defined purpose. All of these are distinct, therefore separate them into the three general types of episode groups. So over the years, CMS has received stakeholder feedback in the former value modifier program through the supplemental quality and resource use report. But recently and moving forward, CMS has received stakeholder feedback through postings and through a technical expert panel and committee. This included 70 clinical experts from over 50 specialties. Currently, which this last bullet shows, CMS would like your feedback on the cost measure development. So if you'd like to read the posting and give your feedback, you can go to the cms.gov website to submit your feedback, and that would be due by April 24th. So where can you go to learn more? The QPP website has a lot of great information, especially under the Education and Tools section. And the QPP website is qpp.cms.gov. You can also get involved in the Transforming Clinical Practice Initiative, otherwise known as TCPI. And this will help with quality improvement strategies. You can also work with your state's quality improvement organization, which would be MPRO for Michigan, Medistar for Wisconsin, and Stratus Health for Minnesota. And lastly, to learn more about the benefits of the advanced APM participation, you can check out the Innovation Learning System, which is on the CMS website. And this slide just gives a more specific place to go for technical assistance based on your practice. So our role at the Lake Superior Quinn is to provide education, technical assistance, clinical engagement, as well as patient engagement. And here are the main contacts for each of the states. We've got Holly in Michigan, Candy in Minnesota, and Mona in Wisconsin. And if you need any direction or have any questions, please email us according to your respective states. And another great resource is the QPP Help Desk. So here's their phone number and email. They're really good with providing help and support with the Quality Payment Program. And here are just some more resources regarding the Quality Payment Program, including the final rule, the quality measures page, and then our website, which we'd like to highlight, where you can register for future events. We have the QPP office hours on May 11th. We have calculating a score for MIPS on April 20th. And we also have other events that you may be interested in. It's lsqin.org, and you can register on our website for these events. Okay, so now today's slides, again, will be posted on our Lake Superior Quinn YouTube page within the next week. And at this time, we're going to pull up the evaluation questions. Please take a moment to let us know how we did by filling these out. And then, operator, if you can please open the lines for questions.
Ladies and gentlemen, if you would like to ask a question, please press the number 1 key. Again, ladies and gentlemen, if you would like to ask a question, please press the number 1 key. Our first question comes from Michael Wall.
Good afternoon, and thank you for a fantastic webinar. My question is there a limit to the number of bonus points that an eligible clinician who's reporting individually can receive?
Yes, hi, this is Holly Stanhart. Yes, there is a limited amount, depending on when you're going to participate. If you're going to select 6 measures, and if you are going to report your priority measures, your outcome measures, or if they're process measures, you require 5 plus 1 outcome measure or 1 high priority measure. But if the remaining measures are high priority, you are allocated 1 point if they are being reported. If they are an outcome measure, anything above the 1 requirement, you would get 2 points for each additional.
So if I understand that correctly, if I reported 6 outcome or high priority measures, then I would be eligible for 10 bonus points?
Correct.
Okay, perfect. Thank you.
You're welcome.
Our next question will come from Ann Ruder. You may begin.
Yes, my question is about the eligibility requirements and the threshold of the $30,000. Is that Medicare charges, which I think was listed on your slide, versus reimbursed dollars?
Yes, very good question. That is the charges that are submitted to Medicare Part B.
Okay, thank you.
You're welcome.
There are no more questions in queue. Ladies and gentlemen, if you would like to ask a question, please press star, the number 1 key. Again, if you would like to ask any questions, please press the number 1 key.
We have some questions that came in the chat, so I could probably address those. One of the questions was if the slides are going to be available. Yes, they're going to be available on our Lake Superior website, so lsqin.org. There's the YouTube page link that's right at the top, so you can access that, and that'll be available in a week. The second question is, I'm an independent pathology group. We are exempt from PQRS, so we have never reported this. From what I understand, we would automatically receive a 0 in the quality area, correct? So that is a very good question because you are considered non-patient facing. If 75% or more of your encounters are, as a group, do not qualify for the quality category, so you would technically be exempt from that. The minute that drops down below 75%, then you would be eligible. The second question is, are there any thresholds that we should try to hit for the quality measures? Yeah, so one of the things that you have to be concerned about is depending on how you report your quality measures, if you're reporting through EHR, through claims, or through a registry, the ultimate goal is that you want to be as close to 10 points as possible. When you take a look at the quality benchmark report that's available on the qpp.cms.gov site, you will take a look at the 2017 benchmarks, and you'll determine, as of today, if you reported at 70% using the specific methodology, how many points you would actually get for that measure. And also, you want to take into account that those benchmarks will change on a yearly basis. So what we see from the 2015-2016 data is not going to be the same as the program progresses. So again, you want to make sure that you try to get as close to 100% total so you could potentially get 10 points.
Our next question comes from John Wagner. You may now begin.
Okay.
So my question is, eligible clinicians that have never attested to meaningful use before, how are they notified, for example, like a mid-level position, how are they notified that they qualify for the MIPS program?
Yes, actually a very good question. So a couple of things are going to be occurring within the next month to 2 months. So depending on if you've never attested for meaningful use or for PQRS in the past in the legacy program, what CMS is going to do is they are going to review your past participation and how many claims you've actually submitted in the prior years to determine if you are eligible. What will happen is CMS will be sending out letters, and they are going to also be creating what's called the NTI lookup tool, which is a CMS site that will allow clinicians to log into the tool to see whether or not they believe that they should or should not be exempt from participating in the MIPS program.
Okay. As a proxy for all of these individuals, is there some way that I would get that letter rather than the provider themselves?
Yeah, actually, from our understanding is that each individual provider would be receiving that. That information is based on what is housed in the National Provider Enumeration System, known as NPES. So if there is old information in terms of their NPI or contact information, or if there's the information for a proxy, that will all be determined based on that information that's being housed in that system.
All right, thank you.
Our next question comes from Kaplana from Memorial Hospital.
Hello.
Hi, I have a question about maximum bonus points. So in one email that we asked, we got a reply saying that the maximum bonus point was 10% of the denominator. So if it's 10% of the denominator, it's like 6 points, right, for the maximum bonus points?
Actually, if you do report all outcome measures, your first outcome measure is required, so that's at 0. And for your remaining measures, it's 2 points if you decide to report outcome measures. If you decide to report on high priority measures outside of the required 1 outcome measure, then you only get 1 point.
So it would be either 5 points maximum if you report high priority, or like 2 points if we need the outcome. 10 points.
Yeah, 10 points, 2 points per measure.
Okay, thank you for clarifying that.
You're welcome.
There's no more questions in queue. Ladies and gentlemen, if you would like to ask a question, please press the number 1 key. Again, and ladies and gentlemen, if you would like to ask a question, please press the number 1 key. Okay, our next question comes from Janice, you may go ahead.
Hi, this is Reed Haza at Stratus Health, sitting in with Jane McGraw here and Candy Hansen. We have a little update on some information about that provider notification, and we sat in on a CMS webinar which talked about the MACs now working in that process, and CMS is kind of outsourcing that to them, and they are going to send those notification letters about qualifying for MIPS to the MACs, which in turn will send those to the TIN level of the organizations rather than to the individual providers. And that was a couple days ago, I believe, when we got that information.
Thank you.
Great, thank you.
We have another question that came through chat. Can you clarify why in quality some have potential of 120 points versus 60 points? Does 120 points position you better than 60? This is a great question. 120 points or 110 points, depending on if a readmission measure is going to be used. That is actually for web interface reporting. Web interface reporting is a little different than your claims, your EHR, or claims reporting. The web interface reporting requires that you report on 11 quality measures versus the traditional 6 quality measures. So web interface reporting is only available for groups of 25 or more and requires that the group actually registers to participate in the web interface, because that then allows CMS to pull out the attributed patients and also present those on a web interface module so you'll report on. So if you have 11 quality measures that you have to report on as a group using the web interface, what will happen is 10 points max per measure, and that would allow you 110 potential bonus points. If you have over 200 hospital cases for your group, then you're also required then to report on the readmission measure with a potential for 120 points. So depending on if you're reporting as a group, if you're reporting as an individual, and depending on the number of clinicians within that group will depend on what you are available to report on as your maximum number of quality points for the quality category.
Our next question will come from Scott Johnson from Physicians Alliance. You may begin.
Yeah, hi. This is actually kind of a follow-up to the last explanation. So, am I understanding correctly then that those who do the web interfacing, is that raising their denominator as well? Because I feel like those who are not eligible for web interfacing and they get graded on 60 points are disadvantaged. Can you clarify?
Yeah, actually, they're not at a disadvantage. It really is, it's actually the opposite in the case where with the web interface, it gives them an opportunity to report as a group. Web interface is only available for group reporting. So technically, yes, they do have more measures that are more points that are available to them, but then they're expected to do more in terms of that data abstraction.
So can you confirm, though, that because you're expected to do more, you're graded out of more on the denominator? Because if it's just accumulating points, then those who get 60 more points get ranked higher. But if it's a ratio, then I could see what you're saying is true. Can you just confirm that for me, though?
Yes, it is based on a ratio.
Thank you.
Okay, we have one more question that came in the chat. Let's see. Do we have to report our urgent care providers? We have never had to report them prior to the EHR incentive. Yes, that's also a very good question. When you visit the Quality Payment Program website, when you click on the quality category, there is an opportunity to look at what Michelle had mentioned, specialty measure set. And emergency medicine is actually a specialty measure set. Because you potentially are billing to Medicare Part B, you will be participating in the program as well, but again, depending on the number of Medicare Part B claims that are submitted in prior years will determine whether or not you are expected to participate and potentially could receive an upward or downward adjustment.
Our next question in queue will be from Leanne Lane from Associates Pathology. You may begin.
I had a question on the independent lab that was exempt from DQRS. So if I'm understanding this correctly, if I'm going to get a 0 automatically or be exempt in that category, I'm never going to reach an area where we're going to get into bonus payment. Is that correct?
That is correct.
But are we still required then to report in the clinical practice improvement area?
That I would have to double check on that for you. I believe that you would not have to, but I want to make sure. So if it's possible, could you please provide me your contact information and we can follow up on that for you.
Fabulous. Thank you.
Thank you. We have another question. I'm sorry. We have another question in chat. Let's see. Do we have to report our, I think we already did that. If we want to report as a group, but the providers in our group use 2 different EHRs, can we still use the EHR option for reporting on the missed categories if we will just be reporting from one EHR for our whole group? That's also a very good question. If you're reporting as a group, you have to use the same reporting methodology for each of the categories. So if you are submitting data for the quality category, depending on the size of your practice and depending on how many people are participating. For group reporting, there are certain methodologies that are available, and that includes EHR, registry, administrative claims, CAP survey, and then also your web interface. So you have to use the same reporting methodology, and we have seen in the past where groups had registered for PQRS, but believe that they were trying to submit multiple files. So whether it was registry and EHR, it can only be one file, one methodology. Very good question.
There's no more questions in queue. Ladies and gentlemen, if you would like to ask a question, please press the number 1 key. Again, ladies and gentlemen, if you would like to ask a question, please press the number 1 key.
We have another question that came through chat. Do we know if the providers get 100 points, they will a 1% increase or a 2% and so on? Again, another very good question. Really, it is benchmarking and comparing yourself against peers. So the example that I often use is that, if you are submitting data and you're at, about 60% for your overall score, and somebody else comes in and their overall score is much higher than that, maybe 80 or 85%. It really is, again, a very budget-neutral program. So it's hard to say, right now if 1 or 2% would be allocated for a certain number of points because this program is very new and because you are going to be compared against your peers. It is very important that, as we cannot stress enough, that being as close to, reporting fully for a measure for data completeness, ensuring that you have enough measures, ensuring if there's opportunities for bonus points to take advantage of those so you will score higher overall compared to your peers.
There are no more questions in queue. Ladies and gentlemen, if you would like to ask a question, please press the number 1 key. Again, ladies and gentlemen, if you would like to ask a question, please press the number 1 key. Our next question comes from James. You may go ahead.
Hi, this is Reed Haza once again at Stratus Health here, and I just wanted to add some information to that question that we had about the quality category with you're doing the 100, or we talked about 110 points versus 60 points for providers, et cetera. And one of the other items there is, what if we're totally exempt from this category because we don't have enough patient-facing encounters? For that one, we have a model from CMS where if an eligible clinician is exempt or is not able to participate in the advancing care information category, that is 25% of the overall performance score for MIPS. They would shift that or kind of set it at 0, and then they take that 25% and shift it over to the quality category. So then you're at 85% of your total performance score for quality and 15% for improvement activities. So we have those 3 categories, one they can't participate in. Now we have a different weighting between the 2 remaining categories. What we don't have information from CMS is if you are fully exempt from the quality category, how do they take that 60% and allocate it to improvement activities and or the advancing care information category? And I've got a note to do a little follow-up on that. The other concern that I heard was the gentleman was talking about having that different, it was 100 points plus for group reporting, the CMS web interface versus a 60-point and self-disadvantage. Well, if you take a step back and think about how the scoring is done, again, you have in 2017 3 categories with 60% being quality, 15% improvement activities, and 25% advancing care information. So those different types of reporting within the quality category, you would have 60 points available, kind of capped for individual participants, eligible clinicians. That 60 points represents 100% of your score for that category and 60% overall for the performance score. So if you take the web interface reporting and you meet the total number there, you're actually achieving 100% of the 60% of the overall performance score. So there isn't a disadvantage. CMS is just saying, depending upon how you report, whether an individual or via QCDRs or direct from your certified EHR technology or via the CMS web interface, as long as you achieve 100% of the total for your method or type of reporting, then you've achieved the maximum available for that category with quality category, which is 60% of the overall score. I hope that sheds a little bit of light on that.
Thank you, Reed. That was a great explanation. Looks like we also have two more questions that popped up in the chat. Again, is anyone aware that CMS has notified their eligible clinicians regarding participation? So CMS is actually a little bit behind in getting those that information out. They're expected to roll that out within the next month to a month and a half, hopefully sooner. The next question is, do you need to register as a group on the CMS website by 6:30 if you want to use the EHR submission method? No, actually, this year it's a little different. In past, if you had participated in the Physician Quality Reporting System, or PQRS, you were required in the past to register between April and the end of June to let CMS know that you were going to participate as a group or as a group practice reporting option known as GPRO. Now they've taken that away. They said, you can certainly submit that data during time, but the only reason why you would need to register at the CMS web interface would be if you decide to report as a group and you want to use the web interface. And I also believe that the CAP survey requires the registration as well. However, but primarily the only reason why you would need to register as a group is if, again, you want to use web interface reporting. For the other methodologies, whether it is registry or if it's EHR or Qualified Clinical Data Registry or QCDR, those don't require specific registration. So that's one thing that CMS has changed for the 2017 reporting year.
There are no more questions in queue. Ladies and gentlemen, if you would like to ask a question, please press the number 1 key. Again, ladies and gentlemen, if you would like to ask a question, please press the number 1 key. We now have a question coming from Stacy Coots. You may go ahead.
We are a relatively small community hospital, and we bill professional fees for multiple physicians, including radiologists, who obviously are non-facing providers. How do we exclude them from our denominator when we're doing reporting?
Hi there. Are you performing Method 2 billing for your critical access hospital?
We're not critical access. We do provider-based billing.
Okay. Certainly this is a little bit out of my expertise. If I can please get your contact information as well, and I can certainly follow up. I do have some additional questions that I need to ask you in regards to that.
Okay, that'd be great.
Okay, thank you.
There are no more questions in queue. Ladies and gentlemen, if you would like to ask a question, please press the number 1 key. Again, ladies and gentlemen, if you would like to ask a question, please press the number 1 key. There are no more questions in queue.
We have another question that came in through chat. It is, will both the slides and transcript be posted and where? The slides will be posted on our Lake Superior Lake Superior YouTube page. That can be found at our website, lsqin.org. And then if you look under Events tab at the top, there is a link to our YouTube page. And the slides and the presentation and such will be available in 1 week.
There are no more questions in queue.
Okay, I think all the questions in chat have been covered, and also if there are no more incoming questions, I think then we can...
Okay, well, thank you for joining us today.
Ladies and gentlemen, thank you for joining. You may now disconnect and have a great day.